Sorry about that, everyone. Let's go ahead and get started. So, my name is David Eames. I'm one of the pediatric residents. I'm a PGY2. Despite what the slide says, I did not catch that one. Hopefully, that is the only typo that I didn't catch. So, this is Pediatric Journal Club, and we are doing this on PICU admissions for our high-flow nasal cannula. And I said, is this a blank check approach? I don't know, blank check was my favorite Disney movie growing up, so that's why I went with that. So, all right. So, getting into our objectives here are to introduce the audience and the learners to the article, study the researchers that conducted this and the institutions where it was conducted, and then review the study's methods, findings, and conclusions drawn by the researchers performing the study. And then hopefully we'll have some robust chat go on afterwards, because that's what I like to do with Journal Club, is provoke discussion. All right. So high flow is a growing trend. Bronchiolitis is one of the most common pediatric diagnoses leading to hospitalizations. There are more than 100,000 hospitalizations from bronchiolitis annually in the United States. And the use of high-flow nasal cannula supplemental oxygen has become a popular treatment method for such illnesses and hospitalizations. Some hospital systems utilize high-flow nasal cannula on the general pediatric wards, and other hospital systems require the patient to be located in the pediatric ICU due to, I guess, the pressure support behind it and just nursing familiarity with the actual equipment there. So after looking into it, it's not really clear that the places that use it on the floor are bigger institutions or smaller institutions. It's more so just some places do it and some places don't. Some of the bigger institutions don't do it on their floor, and some of the smaller institutions do, and vice versa there. So the question I wanted to pose to everyone is the PICU transfer for high flow something that a lot of us are probably familiar with? Is that a fiscally or practically responsible practice of medicine if there's no other cause for the person to be transferred to the PICU? So if they're having adequate oxygen saturations and they're working to breathe, but we want to try and alleviate their effort to breathe by providing them some high flow, is that an adequate reason for a PICU transfer? So PICU admissions for the sole purpose of high flow, what I would posture to say is that maybe they're not necessary, and they oftentimes pose a significant difference in cost to the patient for their hospitalization, and sometimes that's left up to pay by the patient. So the main author of this study is Dr. Robert Willer. He is a DO, earned his osteopathic medical degree at Ohio University College of Osteopathic Medicine. He completed his pediatric residency at Peyton Manning in Indianapolis, and he was a chief resident there. So he currently works as a pediatric hospitalist at Primary Children's Hospital and the Primary Children's Unit at Riverton Hospital. Dr. Willer's clinical interest is utilizing the latest research to provide evidence-based care and maximizing benefit while minimizing harm caused by medical interventions. So the title of this study, which is actually from this month's edition of Hospital Pediatrics, which is the AAP publication, is Implementation of a Weight-Based High-Flow Nasal Cannula Protocol for Children with Bronchiolitis. And so in this study, the researchers primarily aim to determine if replacing their hospital system's current age-based high-flow nasal cannula protocol with a weight-based high-flow nasal cannula protocol would impact the rate of PICU admissions. So this is a hospital that already did high flow on their floor, on their general floor. But what most of the literature out there has shown is that the use of high flow doesn't necessarily help improve the clinical outcome, the clinical course, or whether or not the person ends up needing ICU level care. So they wanted to see, essentially, if they switched what type of high flow levels they were doing would impact that. So the traditional ways to do it age-based. They wanted to switch it to a weight-based. So their initial age-based was an 8 to 10 liter per minute, which is kind of mild. It's based off the age, and the max was 10 liters. But that was not really associated with any improvement in the clinical course, and was actually associated with increased non-invasive ventilation and PICU admissions for this hospital. Take a look at changing it and see what that would do. So the hospital where it was conducted was the University of Utah School of Medicine Primary Children's Hospital in Salt Lake City, as well as two of that hospital system's community-based hospitals. So much like our kind of larger or medium-sized, small-sized academic center here, how we have two, community-based hospitals, or even three. They have two in theirs, but those hospitals also admit children, and they conducted this study there as well. So one of those hospitals has an on-site ICU, but this article doesn't actually disclose whether or not that ICU is a pediatric ICU. It just says that they have an on-site ICU. So Primary Children's is, in and of itself, a freestanding 289-bed Level 1 trauma center. They have over 60 medical and surgical subspecialties, and they employ over 300 providers as a system. 800 pediatric providers as a system, and 3,000 staff members. So pretty large institution as their primary study site. So I want to go over the participants and who they looked at. So the study included patients who met all three of these inclusion criteria outlined below. The age was one that had to be less than 2 years of age. The discharge diagnosis had to either be bronchiolitis or viral pneumonia. They had to be admitted to a non-ICU pediatric ward during the respiratory season in one of the below-listed timeframes. So this was the study that had a implementation of a change, and they looked at the people who met these criteria before that change, and then the people who met this criteria after that change. When pre-implementation time period was 2013 to 2018, and then afterwards was 18 to 2020. So they did exclude anybody with a complex medical condition from the study. So in Journal Club, we go over a statistical sidetrack. This is what I wanted to touch on here. So the type of study that this was a interrupted time series. And so when we think of clinical studies and clinical research, we think of randomized controlled trials being the gold standard of the studies that we like to conduct. However, sometimes randomized controlled trials are limited, and you can't randomize based off of the study populations that you have. So that's where this interrupted time series analysis can offer a next best approach in situations when you're dealing with interventions not feasible for randomization. An interrupted time series approach allows for metrics from two groups to be analyzed and compared with respect to a time-specific intervention. So to me, this was easier to kind of comprehend once I looked at the graph, so we'll get to that in a little bit. But the intervention that was taken in this study was basically they went from having this age-based high-flow protocol, and they had a bunch of attendings, residents, nurses, respiratory therapists, medical librarians, medical researchers get together and develop a new weight-based high-flow protocol to replace their original age-based high-flow protocol. And so this goes over those two different protocols. The weight-based one, we already kind of touched on the age-based. So the weight-based one is 2 liters per kilo per minute, maxing out at 10 kilos, putting them at a max flow rate of 20 liters per minute. And they wanted to look at and see if that would improve kind of the clinical course of the kids who were receiving high flow on the floor to make it to where they didn't require PICU admission. So the outcomes that they looked at, the primary outcome was whether or not the kids got admitted to the PICU. This included any admission to the PICU, whether it was from the emergency department, from the general pediatric ward, from a transfer, from a referring hospital. The study also didn't disclose whether or not these referring hospitals were listed as the 2 other places where the study was conducted, but I would assume by the way the article read that that's what it was talking about. The secondary outcomes that they looked at was the mean hospital length, so length of stay, cost per encounter, invasive medical ventilation, so whether or not the kids ended up on a mechanical vent, and then whether or not they ended up on non-invasive ventilation, CPAP or BiPAP. So some statistical analysis. So the data extracted from these outcomes was analyzed using the interrupted time series approach to compare the outcomes across the pre-intervention and post-intervention seasons. So they also had to be admitted during a respiratory season. It wasn't just those time frames, but respiratory seasons during those time frames. Immediate changes in outcomes and any change in trend of those outcomes were analyzed using a linear regression model for mean continuous outcomes and a quantile regression model for median continuous outcomes. The difference there is the median and the mean. And then logistical regression was used for categorical outcomes. So this is where I'm getting into the results, and I'm going to try and exit the slideshow because some of the numbers here that I wanted to talk about are in the notes section. So hang on just a second. All right, so what this graph is showing you is the proportions of patients who met what they would have been getting on the weight-based flow when they were on the age-based flow. So this first kind of numbers down here and this line down here is the percentage of patients who met their weight-based flow when they were given the age-based protocol. So as you know, weight is not directly dependent upon age. It is related, but some kids are heavier than others and some are lighter. So you were seeing numbers in kind of the, like, 7 to 12 region, or kind of single digit to the teens regions, of people who met an appropriate weight-based high flow rate when they were given the age-based protocol. And then after they implemented the weight-based change, which is represented by this dotted line, this is the percentages of people who met their weight-based range. So really, it was a significant difference in the number of kids that received an appropriate weight-based high flow rate when comparing before to after the change that they made in the protocol, which is what you would expect. So these are the results of the outcomes. So this first graph, represented by A, is the proportion of patients admitted to the ICU for high flow after receiving the high flow, weight-based high flow change, represented by the dotted line. So the initial slope, which is a positive slope, is the seasons prior to the change, the dotted line representing the change, and then the slope and numbers after that, that is a negative slope, is what represents the admission rate after that. So they did see a statistically significant an immediate decrease of 4% of ICU admissions, and that was a 95% confidence interval being somewhere between a decrease of 5.1 and 4.0. The next graph here, B, represents the mean hospital length of stay in hours. So this looks at whether or not the high flow, when it's dosed at a weight-based rate, affects how long the child is in the hospital when compared to an age-based, which is what most of the other studies that show that it's not made any change have done. They've looked at age instead of weight. So when looking at the weight, it did have some change here, but it was not statistically significant. So even though you see a good downtrend, their statistical significance wasn't enough to quantify it. The next one is C. That's looking at cost per encounter. And so there was an immediate decrease in cost per encounter of about $661 per encounter. That was statistically significant, and the confidence interval was somewhere between $1,006 and $316 per admission or per encounter. D represents the proportion of patients treated with high flow. That doesn't read right. Proportion of patients treated with high flow, the absolute decrease. That one is the, okay, yeah. Who ended up needing high flow versus not, I guess, after, before and after. So I guess they're looking at the numbers. Yeah, thank you. And then E was the patients treated with non-invasive ventilation after this change was made, which they did see a statistically significant decrease of 2.3% of patients who required non-invasive or CPAP or BiPAP, so they made this change. And then the last graph is patients treated with invasive mechanical ventilation. So going from non-invasive to invasive, being on a full vent. And there was a decrease there, but it wasn't statistically significant. So what does all that mean is what was discussed in the conclusion section of the article. And they said that the implementation of the weight-based high-flow protocol on the general pediatric ward was associated with a decrease in PICU use and non-invasive ventilation use. So although the ward-based high-flow protocols are often implemented to reduce ICU use, the recent studies, like we had talked about, didn't really suggest there was any improvement. And actually, there was, in some cases, a paradoxical increase of ICU use after putting a kid on high flow on general pediatric floors. But those studies mostly, like we said, looked at age-based high flow rates, somewhere between 8 and 10. And the findings that this study got were based off of the weight-based high flow rates going up to 20, which ended up being a much higher flow rate, and more kids got their weight-appropriate flow rate in this study. And that did show that there may be some success there. So with that in mind, hopefully some people are waiting to talk about the thoughts or feelings they have about doing something like that here.
Can we go back to the graph?
Yep.
Let's talk about those. So this is, I mean, is this a pretty common presentation of data that most people are used to seeing?
No, not really. That's why I would use it as my sidetrack.
One of the reasons that I like this study is because it gives us a chance to talk about it. So does everybody make sense of those results graphs, and what does it mean? So for instance, when I pose the question, why is there such a steady increase in a lot of these factors in the 5 years up to the implementation? Does anybody have thoughts on that? So look at that. So that's saying in the 5 years leading up to the implementation, there was a steady rate of rise of the percentage of patients who needed to be intubated and ventilated. Well, does that make sense? I mean, it doesn't to me entirely. So I mean, like so I want to make sure it's not an absolute number. So if they're just increasing the size of their unit, you know, that'd be one thing. I mean, again, to be able to, like, there looks as though there's a clear difference in the pre and post.
What bothered me too is they talk about the slope a lot, but they only have 2 points.
It talks about a lot, yeah, the slope.
And
so I get that. So the idea is that if you have 5 years of data that shows this clearly established positive trend, the fact that slope would change at all to a negative is a big change in slope. I get that.
Right. But
what
you can't do like
the heck does that mean, right?
Analysis on that slope point.
Yeah.
Because then my future is bigger.
Yeah. Exactly. Yeah. So certainly, if you have five years of break, maybe they're planning on doing this, right? Maybe they're planning on collecting data for the next few years, and we'll be able to report out on that. But yeah, there's a lot here that just seems a bit interesting, unusual to me. And then their first result, that chart is just showing whether or not they were able to adhere to their own protocol, which they mostly did. I mean, I'm glad for that. But, and it shows that the age phase does differ in terms of what kids are going to get compared to the weight phase. What else did people think about? I like David's point, not having enough data points. Anything else that struck people?
I think Dr. Ward wanted to make a comment, but.
Can you scroll over to their methods, the slides you had for their methods? because you listed as you're finding for that, you listed kind of what their protocol is for the high flow, and it's patients less than 2 years of age. And that's what they were going to do a weight-based high flow recipe for. But if you look at their primary outcome, it's not specific to those patients. It's specific to ICU admissions. So, you may have, if that's how that's how I'm interpreting this, is that, yeah, they listed the participants for what they did the protocol for, but their primary outcome is all PICU admissions. If you go to the other slide for your primary outcome. And so they're doing one specific thing, and then they're measuring all these other things, which, yeah, there's your primary outcome. Any admission to the PICU from the ED and the general wards. So, I mean, this could be teenagers who are suicidal, it could be traumas, this could be all sorts of things. And so that's, unless y'all see something different, that's how I interpreted that. And there's so many confounding things that's going to contribute to your PICU admission. Besides this protocol, and there may be increases or decreases. So I had a major issue with this paper because of that.
So when I read the paper and looking at it earlier today, it does sound like it was any of the PICU admissions, but based off their inclusion criteria, I would have assumed that the admissions they were talking about were only admissions for bronchiolitis, but it wasn't worded that way in their actual inclusion criteria.
I think it says pro bronchitis encounter, or pro bronchitis.
Yeah. I mean, I think that they looked at the percentage of patients meeting inclusion criteria that required the ICU, and that's what this A graph is showing.
So I think
Yeah. Where does it say that the primary outcome was the all cold ICU admission?
It's on.
So
Yeah. Yeah, but in the outcome, the primary outcome is specifically defined as everything.
everything, yeah. So it doesn't say whether or not it's limiting these as bronchiolytic admissions to the PICU or kids who received high flow on the floor admissions to the PICU. It just says all PICU admissions.
So one would hope that it would only be for the inclusion, but.
Right.
Don't say
So
that.
I don't know if anybody online can hear what Dr. Finkler is saying, but he's saying you would hope that it would only include those bronchiolytic admissions, but it doesn't actually say that in the article.
Yeah, and that I think that's poor. That's poor quality stuff. I mean, they should have really specified that. And it may be that this was too much work to do. I mean, that would be a lot of work to go and pick out every single viral pneumonia or bronchiolitis patient to go back. What they did is it looks like to me they kept it simple, is that this is what they started with their protocol. And then they've looked back from whenever they published this retrospectively and looked at PICU admissions and did it influence it. And so there's lots of associations and assumptions with that. And so for me, this is a very flawed paper.
So with that in mind, because when reading through it, I was trying to give them the benefit of the doubt the whole time, assuming that all of these flaws in what they were saying were actually just covered. If it's that flawed of a paper, what do we think about the AAP publishing it?
Well, so all the secondary outcomes are on a pro bronchiolitis encounter. And
I'm reading it more and more. I think that I'm with Eames. I think that they did it right, but I think that they wrote it.
I think they wrote it very poorly, but I think that I would assume if the AP published it, they did it correctly.
Well, but that's hard to not make assumptions, right? So, yeah, I think this study definitely has flaws. But in theory, if they did it all correctly, it's at least interpretable for data to look at. Okay.
it's also unclear though too, even if it is, looking at ICU, is that really clinically that significant in any way? I mean, sure, there's a little bit of cost involved, but.
I found it interesting looking at the cost. So if you look at the ICU utilization, in theory, like there was a decline from close to 25% or 20.22% down to 17%. It's like a 5% decrease in ICU use for their group, and yet the total decrease in cost, or the average, was like $600 per encounter. I would have thought that, because usually the ICU stay would be a couple days, maybe, so I would have thought that price difference would be a lot bigger. The other thing is the length of stay had such huge variability, right? So it was a negative 0.8 for a median or mean, yet the range was negative 10 to plus 8. So pretty big.
So pretty broad.
Yeah.
Now, they did do it in hours, not days, so that's kind of blow it up a little bit.
Oh, yeah. Yeah.
On
But
the top,
anytime it crosses zero.
Oh, yeah.
Go ahead, Dr. Ward.
what were some other, if we're going to be pessimistic like I am with this article, what were some other had with it? They put it, they did mention a few things, but I mean, it seems like the question I would have with when I'm looking at this article and why I was a little interested is, can we do high flow on the floor? Is it safe to do that? Where I came from in residency almost a decade ago, we were doing it on the floor. So to me, safety would be important, right? I mean, don't y'all think that would be something that should be looked at? And it doesn't look able to do that with this study. And I mean, they were able to do cost analysis and, things like that to that detail, but they're not able to track pneumothoraces or, the number of rapid responses on the floor or the number of code events that happen on the floor with doing this. And so, I mean, to me, it just was like we decreased PICU admissions. And was that because of the high flow weight based? I don't think we can say that with their data. But what are y'all thoughts on this and safety, and then how to use high flow?
So my thoughts were that they did comment on not looking at pneumothoraces and saying that they couldn't tie any correlation there as to whether or not it would actually be caused by the high flow.
But it's still, I mean,
I
just
think
like a drug, you should list, if it's a complication, it would be important to know, would be my thoughts on that. You should still at least list it.
Right. I think they looked at the metric of PICU admissions being kind of, an adverse event outcome, but that's much further down the road as to whether or not, was there a rapid response call, but the kid didn't end up in the PICU, or did they develop a pneumothorax, but they didn't end up in the PICU. So it's kind of left for your interpretation there.
And part of that thing is their
Which
question
floor?
was, is this safe on the floor? Is this better than the Eames system? Now, did double some of those flow rates, or would your point like, hey, that wasn't an impact.
I mean, the study just flat out wasn't designed to answer any of these questions.
No.
The study was, somebody read the articles about using weight-based dosing for high flow, wanted to make a policy change, and then had the good idea to collect data for it, which is part of the UI process, but this was perhaps imperfectly implemented, and it doesn't get to any of the questions that were raised.
And it does feel more like UI than like a two.
Yeah. And so there are lots of other better studies out there that look at this. There's not entirely conclusive data one way or the other. I was telling Eames, we were chatting about this. I mean, just like Dr. Ward, I trained doing high flow on the floor. When I came here, I wrote a policy to do high flow on the floor, and we just decided not to do it just because our numbers made sense and keep it the way it was, essentially. There's an entire camp that doesn't necessarily buy into the high flow for bronchiolitis is even needed. It treats the providers more than the patients. So there's certain bronchiolitics that definitely need it. There's a lot that definitely don't, but there's a huge number in between where they end up on it without any conclusive improvement of outcomes.
Yeah, and I'm curious to know, like, what do the residents think? Like, when would you even start high flow? Like, how do we objectively go about that? Of which patient gets it, and are there issues with that?
So it seems, I mean, my thoughts there is just that it seems like every time we do this, it's based off of how the patient looks, not actually how they're doing by measured and recorded metrics. So we don't, right. Respiratory rate would be, I guess, included in there, like Dr. Masada is saying, because of how they look in their work of breathing, but their oxygen saturations when we start high flow oftentimes are in the mid to upper 90s, which is right where you want it. So if one kid looks worse maintaining their sats versus somebody who looks fine but isn't, who's going to benefit from the high flow, and how do we make that decision? It's a wide interpretation.
And Yaz, how fast is fast to consider?
I think it depends on the age of the patient. So, like, I think I would be pretty uncomfortable if we had, like, a 10-month-old or 1-year-old, like, in the 80s, 70s, higher 60s, that kind of stuff. So, just as a baseline.
You know, I was like looking for, like, is it a, 2 or 3 times the normal rate? Then,
Yeah.
I mean,
And
it
then
varies from minute to minute.
the study too. Yeah, I would agree with you guys. That's pretty fast. It's also working on the assumption that just because they have bronchiolitis and we put them on high flow, they're going to benefit from it. There can be harm with it. At least from what I've observed, you're pushing air down, and some of these kids have very narrow airways, and all this mucus that they're trying to cough up, and it may potentially be doing harm. I've had kids where we actually decrease the high flow, and people think, well, that's crazy. They're really working harder, and decreasing the flow may actually help them, make them less agitated, and they're able to cough up a little bit better. And I think the biggest thing is the suctioning, the attention to the need of suctioning these kids out as best you can really can help from getting worse. But yeah, they're assuming this higher flow is just better for patients, better for the bronchiolitis, and I think that needs to be cautiously looked at with each individual patient.
Yeah, agree completely with all that. I mean, and again, and what to one of your earlier points, Dr. Ward, one of the struggles is identifying the correct patient, and so when we wrote our policy, we spent the longest time defining the exclusion criteria, because the last thing you want to do is, for lack of a better sense, like applying high flow as a Band-Aid to patients that actually need positive pressure ventilation, and essentially putting yourself in a scenario where it's being utilized on patients that have no business being on high flow floor. And so that was one of the reasons that we ended up fixing the idea at the time. And the studies for whether or not it's actually providing positive pharyngeal pressures or not in kids at the rates that it's being used for bronchiolitis also is a bit thin. I think that the humidification, and to speak to the importance of mucus clearance, the humidification of a high flow circuit, I think often can be just anecdotally without science-backed statement, but I think that might be part of why it's helpful. So to answer Dr. Eames' question, who wants the high flow policy on the floor after even study, or irrespective of previous study?
What I'm wondering is, could we have it where if we do have someone who only needs high flow, that'd be the only thing they go to the ICU, can they go there as floor status, because everybody there is comfortable with the equipment?
You could, but
because that's the real holdup, is that we're not comfortable with them.
That creates a whole nother nursing
that would create a whole
nightmare.
But or to design a policy where patients would go to the ICU for establishment of high flow, and then after 12 hours, if they're better, then they come back out for 4 and then do the weaning on the floor. I mean, there's 101 ways to do this. Again, part of the idea of Journal Club is to look at the literature and try to be as objective as we can. And I think that most people sound like we're concluding that the study wasn't in the end helpful in making that determination.
Yeah, what do the residents feel? What would be a safe, if we were going to do an N of 1 study, what would be a safer patient to put on the floor with high flow? Like, what would be the disease process? What factors do you guys think?
I mean, I think probably, just speaking for myself here, I think probably I'd be more comfortable with a patient I was familiar with versus taking a patient who is, you know, stabilized in the PICU and then transferred out that I'm not as familiar with and haven't had the, I guess, benefit of being able to watch them, you know, get to this need that we would address with high flow. But if, I mean, it's hard to say, right? Like, it's, you know, probably a bronchiolytic child that we've seen a ton of, I mean, who's maintaining their oxygen saturations, but just is uncomfortable, you know, breathing, and which is the one that I'm specifically thinking of, is just a patient who was on the floor maintaining sats, but was working hard to breathe, and lots of people were stressed out about the work of breathing, but they didn't have any vital sign changes based off of it, other than a respiratory rate.
Yeah, I think, like, Dr. Worth, to chip in there for, like, the resident's perspective, I think it really varies on the complexity of the patient. So if we have, like David was saying, like, or Dr. Eames was saying, like, a straightforward, like, asthma exacerbation or bronchiolitis that has not had a history of, like, intubations and several other, like, issues going on, potentially septic, et cetera, like, if they're just really straightforward, you could try them on the floor and be somewhat comfortable with it. But I've also seen, like, bronchiolytic babies or whatever in the PICU on high flow, and then they get just so agitated, like you were saying, and then you need a Precedex strip, and you need this, and you need that, and I think that would escalate anyway to a higher level of care. So it's kind of that, like, going back and forth situation.
And I think also having the availability of having an attending in-house would impact that greatly, right? So if you have day shift happening, which is what we've kind of done in the past, is we can put kids on high flow on the floor during day shift and watch how they do, and if it truly does benefit them and they're still requiring that flow overnight, then shift them over to the PICU, pending availability. But, you know, if it's the middle of the night and the residents are the only providers here, and a kid is needing high flow or having a worsening respiratory status, I don't know that all of us would feel comfortable making that decision to change it, and with the equipment and the unfamiliarity, handling that on the floor. All right, hang on, I'm trying to see what Dr. Henshaw said. Dr. Henshaw, I'm going to unmute.
So I was just asking Dr. Ward about the place of capillary gases in these kids, because, you know, being that I'm one of the older faculty members, and I've told many of you that I'm used to watching kids work hard to breathe, I have a different tolerance level than many of the respiratory therapist, nursing staff, and maybe even the residents and other faculty at watching kids work hard to breathe for a long time with bronchiolitis. So I was just trying to figure out what would my criteria be if I'm standing at the bedside to say, yes, this kid would benefit and should go, versus this kid is let's just continue to watch. And I don't know that there is a good answer. I'd be glad for input to help with that question.
Yeah, so if a child is not, I think the most worrisome kids I would have to be on high flow on a floor setting is going to be the younger bronchiolytic patient, the one that's a couple weeks old, or maybe a premature child that's, you know, just a few months old. And if they have quite an oxygen demand, I think the blood gas would come in more handy, because if you're giving them oxygen and you're keeping their sats up, you may be masking their degree of hypercapnia. And for that, it would, you know, this is in the setting that they're very junky, they're working really hard to breathe, requiring frequent suctioning, maybe not hearing great lung sounds. You know, you may have a higher yield with your capillary gas showing a higher CO2, where you may want to move that patient to the PICU, where they can be closer observed and may need non-invasive ventilation. So if they're requiring a lot of oxygen, if they look really bad, a lot more fatigued. I mean, some of them are just sleep deprived, hungry, ornery, and are giving out for those reasons versus it purely from a respiratory reason.
Yeah, so I feel like tone was always a big thing for me in deciding when to escalate care before times of high flow. Once their tone starts to drop, then I became very concerned. If they're still mad, angry, and interactive with good tone, but very tachypnic for a few days, I didn't tend to be so worried.
Yeah, I would say the worry kids were probably going to be to the unit. If it's those type of kids that you're worried about, those are probably going to need to be watched in the unit and make sure they don't throw a mucus plug and all of a sudden have an apneic event or so, or just a big desaturation.
All right. Thank you. That was good.
Dr. Eames, are you gonna email the author the question?
They didn't list his email address in the thing, but they did give a physical address, I think. So maybe they did give an email address. I don't know. Yeah. I'll email him and tell him it was terrible. Certified letter and track it in the mail. There we go. That's what we'll do. So we know when he gets it. Yeah.
Yeah. Find the data.
That was a joke for everybody that's important and still listening. Afterwards, getting me in trouble.
No. I think he mined the data. I don't think that they designed this and moved it forward. I think it was completely mined and looking retrospectively, and they did all patients. It's what it's.
Probably.
Good work, man.
All right, thanks.